I'm starting the life. So Victoria, yes, no, that's when I'm starting the Facebook life.
Okay, we're ready. Okay, I think we're good to go. Testing, testing. Loud and clear. Testing, testing. Loud and clear. Okay. Okay, well, good evening, good afternoon, good morning, or whatever it may be according to your time zone, and welcome to the 24th edition of the Medical Reality Talk Show with ICMFEL, which stands for the International Christian Medical Fellowship. So today we have an interesting topic by an amazing speaker, but before we begin, let's all bow our heads and start with an opening prayer. So please join me in praying. Okay. Dear God, we thank you for today. We thank you for this privilege to be here to learn your word, your knowledge. Oh God, we thank you for the speakers who took their time to come, to prepare the message, to prepare whatever they have for us. We pray that, Lord, that you open our ears to hearing and that this may touch someone out there and may help someone out there, oh God, and that through it all, it will be to bring glory to your name. In Jesus' name we pray. Amen. Amen. So welcome again, everyone. My name is Dr. Victoria Maniele. I'm the host for today, and I am joined by Dr. Hart, Dr. Jonathan Minagogo Hart, as well as Ms. Pauline. So Dr. Hart is a cardiothoracic surgeon who has an amazing topic for us, which is congenital heart disease. So you might be wondering, why are we talking about this topic today? So if you don't know, this month, although it is World Cancer Day, from the 7th to the 14th, actually, is the World Congenital Heart Defect Awareness Week. So we brought an amazing topic by an amazing doctor. So he will talk about this topic. We'll have a time for a Q&A shortly. I will let you know after the presentation. And so hold your questions, hold your thoughts until the end of the presentation. So without further ado, I'm going to hand over the speaking platform to Dr. Hart, who has the presentation ready for us. Dr. Hart, all yours.
Dr. Bala, are you set? Okay, greetings to everyone and welcome to this discussion. It's not really a presentation, it's just an overview to set the platform upon which we can have this discussion. And let me remind everyone that this week, from the 7th of February up to the 14th, is World Congenital Heart Defect Awareness Week. So we've been involved in creating awareness of congenital heart disease in Liberia, considering that this is an area in Liberia that have never been touched. No one have over the past venture in discussing these things. But the reality is that there are a lot of children living in Liberia that are suffering from congenital heart disease. So from this organization, we think that it's necessary that we start a discussion on this crucial issue so as to create awareness on the need for intervention in such. It's unfortunate we cannot get our co-guest, student Dr. Pauline, so I will go through the brief summary for her. Next slide. Okay, we all know the heart is a structure in our body, and the only function of the heart is to pump blood. Okay, that's the only work the heart does. It delivers blood that is rich in oxygen to our body tissues, and then it takes blood that are poor in oxygen and carries it back to the lung for refilling. That is the only function of the heart. However, it remains one of the vital organs of life, without which there will be a total impossibility for life. It is one of the earliest organs that developed during embryonic stage in life. So because every other structure will need blood, the heart must start working before other organs can be developed. So God set it up in a way that it is one of the first organs that development takes place in. And then no secret, okay, it is also one of the organs that we have a lot of defects and diseases affecting during development stage. So, okay, so when we say congenital heart defects, we are talking about disease in the heart that occurs from birth. That means the child gets that disease while in the stage of development in the mother womb. Okay, so it affects the structure of the heart. It can be between both chambers. It can be with the vessels that carry the blood and bringing blood from the heart. So, and then it can happen any part of the heart, but the underlying cause is that they occur during birth. It is something that the child is born with. It is the most common birth defects in the world. Is the commonest cause of death among birth defect related death. In America, and other part of the world, the incidence or the prevalence of congenital heart defect has gone as high as 1 in every 100 live birth. So it means that for every 100 children born, one child stands the risk of having congenital heart disease in America. The research conducted in Liberia, okay, puts Liberia at a prevalence of 8 out of every 1,000 children born in Liberia. So in Liberia, for every 1,000 children that are born, 8 of them stand the chance of having congenital heart disease. And we say that more than 50% of these children will need surgery before the first year of life if they must survive. More than 50% of them will require surgery. And among that number, 21% of them, at least 21%, must have surgery before the first 30 days of life if they must survive. And another 40% will require surgery before the first birthday. So we see that a total of 40% children, we must intervene from that to the first birthday if we want them to have the chance of surviving. And early diagnosis, and intervention is the hallmark, to prevent complications and increase, or survival. So that is why we always advocate for early diagnostic screening and diagnosis, so we can be able to identify the problem earlier and be able to intervene as soon as early. Okay, so if you look around here, you will see this area of the green shadow in the map, the darker ones. These are the prevalence and the distribution of congenital heart disease in Africa. And where the centers are, you will see those are the shadow white ones that we have in. Okay, don't have the pointer here together. Next slide. So in sub-Saharan Africa, let's say Africa and Asia are the two largest continents that have the highest number of incidents and deaths occurring. And I think we can explain this on the fact that Africa and Asia are the two largest continents in terms of population. And also, they are amongst the two underdeveloped continents in terms of development and technology advancement. So it is no surprise why the incidence of congenital heart disease as well as death-related congenital heart disease are high in both Asia and Africa. In the Americas and Europe, the rate is very low. Like in Africa, about 300,000 plus children are born annually with congenital heart disease across Africa. Whereas in Asia, we go up to 400 to 600,000 children be born with congenital heart disease. Now, majority of these cases, we cannot really put our hands on the underlying cause of the defect. We cannot point out one thing to say this is the cause of congenital heart defect. However, there are factors that we consider risk factors that increase the chance of a person or of a child, having a congenital heart disease. Okay, but the commonest factor identified are the environmental factors, and especially those occur during pregnancy. In the early stage of pregnancy, the first and second trimester of pregnancy, when the organs are being developed. If the mother, a pregnant mother, is exposed to these environmental hazards or toxic substances, they increase that chance of born a child with congenital heart disease. Others can be acquired genetics. We cannot really tell genetic cause. We can identify the gene sequence that are involved, but there are not theories. I tell you that some genetic mutation can occur in this case. The kids can be born with heart disease. Amongst the environmental factors, we have cigarette, smoking, alcohol consumption, some drugs the mother take during pregnancy, increase the chances of the mother having a child with congenital heart disease. So we can, next slide, please. So we are seeing that, if a mother, a pregnant mother, constantly takes in alcohol or continuously smoke cigarette, tobacco, she will increase her chance of having a child with congenital heart disease to sixfold as compared to the normal population. So we advise, pregnant mother, or mothers planning for pregnancy, to limit the appetite for alcohol and smoking if they do practice such thing. And it is one of the leading causes of congenital heart defects, around the world. The next ones are the medications we take, the diazepam, the acetylcholine, the ibuprofen. Most time, women having menstrual pain, they want some analgesic to quiet. I see most of the time they call me, can I take ibuprofen? I'm like, well, I'm not OBGY, but I'm not sure it's too good. So, we come to tell you, that these drugs increase your chance of having a child with congenital heart disease only if you are using them while you are pregnant. So we are not saying do not use them during lifetime, but we are saying that when you are pregnant or you are not sure that you are pregnant but you miss your period, be mindful on how you take these drugs, because taking them in huge quantity and increased frequency will increase your chance of having such child. We said genetics involved in it. We have Down syndrome, we have Turner syndrome, we have Klippel syndromes. A lot of syndrome are associated with congenital heart disease. As per research, Down syndrome is the commonest syndrome associated with congenital heart disease. Even this research done at the John F. Kennedy Medical Center in Liberia, also showed that Down syndrome was the commonest form of genetic syndrome associated with congenital heart disease. The issue about Down syndrome in this case, it makes the management complex and complicated, because we know that the Down patient, they are special patients. You cannot change their cognitive function, you cannot change other developmental pattern. Now, what do we do with the kids if they have heart defect and they have Down? we already have limited resources. Okay, should we, take this case in, treat them, knowing that we're not going to alter the down part, the pattern of the Down syndrome, and the case will come out and there will still be problem to the family. So a better challenge in Africa, how we manage children who've had different and associated Down syndrome. Currently, like bro, we get like 7 of them. Just yesterday, I was speaking to one of the parents. Okay, he was trying to raise money to send the child. It was a burden for me to try to convince him that we can change the child behavior patterns as it relates to the heart pathology. But it's a serious problem. Okay. Okay, mother with diabetes, okay, that diabetes mother, okay, are also increased risks of having babies with congenital heart disease. So you want to control your blood sugar when you are pregnant to make sure that you control your sugar level. Okay, these are just the very few names. Okay, we describe the various type of heart disease without diseases. I don't want to go into them because I'm not sure the public already understand, okay, what we discussing. But in short, the defect can either be hole in the heart, that be communication between one chamber of the heart and the other chamber, abnormal communication, okay, that the atrial septal defect, the ventricular septal defect. It can be, okay, communication between the blood vessels, the arteries or the veins, okay, and it can be complex, sometimes complex, okay, a combination of the defect, the vessels, complications, and other defects, okay. So when they get complex, okay, the terminology goes hard. So, but just know that it can range from simple abnormal communication between arteries and veins, or holes in the heart, as I can say it, to a complex system that will be necessary to describe here. Dr. Bala. Okay, what are the signs and symptoms that you should when you see a child presenting with? You can say, okay, I need to do further investigation. The case, first of all, they will have growth, retardation. That growth pattern will relatively be different from their peer. They have rapid heartbeat. They have problem breathing. Some of them have persistent respiratory infection. So you see the child, the mother keep carrying the child to the hospital. They saw that pneumonia, they keep treating, giving all antibiotics. The child is still, having that pneumonia. You should raise a suspicion that the child has something else. In the later stage, when it is not being controlled, where the child is having legs start swelling, okay, the eyes and all begin to get swollen up. Okay, sometimes they start getting blue face, blue lips, blue fingers. Okay, the child cannot play actively with his friend. The child runs, he gets tired and too fast. Young babies, when they are eating, on feeding, okay, when the child breastfeed, the child has to pause. Okay, take the breast from his mouth, prepare to breathe again before the child continues. So these are signs when you see them happening in your children, take them for further investigation. Okay, the treatment option can be medical, which is palliative, meaning medical is palliative for most of our defects. The gold standard for treatment for Q, treatment is surgery. But in the meantime, okay, the medical people can manage the patient complications. Let's assume the child is constantly being blue. The child has no oxygen. You can put the child on oxygen, okay, to increase the oxygen saturation. If the child having swollen face, swollen limbs, it means that the heart is not pumping blood forward. The water is sitting back in the child's body. You can put on diuretics. Okay, so a lot of medical therapy to keep the children a little bit stable while we prepare for surgery. Okay, so the treatment option is not, you can cure them, but you can manage the defects. Okay, it can be both open surgery or interventional cardiologists. Open surgery is the one that we're going to open the chest, stop the heart from beating, okay, and then expose the heart to the external surface and work on the heart. But there are situations where we can pass needle of structure through the veins and goes to the heart and just solve the problem there. So there are two options for the once we have this patient earlier and we intervene, they have the potential to live up to that 50, 60 years. So we are seeing that children with congenital heart disease should not be discriminated against. Okay, should be given a chance to live. Now, this is where this whole discussion is about prevention. How can we prevent heart disease? This is our primary goal. Okay, is to prevent the disease from happening. First, okay, on the highlight is to have vaccine against rubella. Remember, rubella is one of the risk factors for congenital defect. Now the congenital heart defect, but most rare defect, rubella is implicated in it. So if government can increase, okay, the availability of vaccines against common, viruses and bacteria that affect child growth and intrauterine infection, we think it can help to reduce, okay, children's risk of being born with congenital heart disease. We cannot overstress the issue of alcohol and smoking. Okay, we keep saying it is the leading cause. Research has proven that it has been the leading cause of congenital heart defect. So we advise pregnant women, okay, to avoid smoking and drinking habit with pregnancy. Self-medication, if you think you are a pregnant woman, you think you need medicine, go to the hospital or to a clinic and let the doctor or the health worker provide you a perfect prescription, because he or she knows the type of medications to give you that will not harm the baby. It's not because your friend took a certain type of medication during pregnancy, and when you get pregnant, you feel the same symptoms, and you call, oh, sister, I'm having this. She said, oh, yes, when I was pregnant, I take this medication, and you go and buy it and take it. No, go to your health care provider. Let him or her, prescribe for you what is needed. If you are pregnant woman, you have diabetes, make sure you control, okay, the diabetic. If you are a childbearing lady and you are planning to get pregnant, you know that you and your partner planning to have a child, we advise you to start folic acid supplements. It's very good. They help increase, okay, the risk of cardiac disease by high numbers. And if you are also pregnant, continue the intake of folics, okay, until you can give birth to your child. We think if we can implement these preventive measures, we can reduce the rate by a greater percentage. Thank you for listening. We take your questions now.
Thank you so much, Dr. Hart. Can everybody hear me? I hope you can hear me. Okay. Thank you so much for the lovely discussion that you just presented. So we're going to have a little Q&A session. I have some questions prepared, and while I'm doing this section, you can feel free to unmute and ask. So since most people here are not really a child get diagnosed with a congenital heart disease, for those who want to know. Yeah.
I didn't get a question.
How does a child get diagnosed with a congenital heart disease? Is there a test to do? Are there something to look out for apart from the symptoms? Is there any specific way?
Okay, if the parents brought the child to you and then you identify these symptoms that we discussed, like difficulty feeding, easy fatigability, poor exercise tolerance, blue discoloration, and you have the suspicion of heart disease. Ultrasound, we start from down first. Chest X-ray can be done in an experienced hand. Chest X-ray can be done. Okay, in most of the times for children, understand that the shoulder of the heart, the shadow of the heart on the chest X-ray will look enlarged. But if you're not experienced, when you see that, you will see the child have an enlarged heart. But in an experienced hand, you can note that, okay, you know the dimension of a baby heart compared to a normal one. So we advise chest X-ray first. Okay, rule out other lung pathologies that may present in similar fashion and a heart disease. If you have done that and you can find the cause of the child's symptoms, ultrasound in our low-income setting, ultrasound, okay, can also help to diagnose it. And if ultrasound cannot help us, which of course, in most instances, ultrasound will only give you some findings that will suggest that the child has heart pathology. The diagnostic tools of choice nowadays is echocardiogram. So if you have done all the other simple tests and you still cannot conclude, okay, your disease, do an echocardiogram. It's almost like the ultrasound, but okay, a little bit advanced. It helps you to see all the tumors of the heart, all the structures of the heart, and that can help you. And there are some instances you will need, okay, catheterization. Okay, you have to put a catheter through the blood vessels, okay, to make further diagnosis or to confirm further diagnosis. But if you just have an echocardiogram, it's enough for you to have diagnosis of the patients.
Okay, awesome. So the symptoms, the physical exam, X-ray, ultrasound, and echo, it depends. Okay, So I hope that answers for everyone.
And just to add up, okay, we can also diagnose pregnancy.
Oh,
Okay,
yeah,
in utero. So we can, like the normal screening of ultrasound screen of a pregnant woman, the ultrasound have a high indices, okay, to raise suspicion of a heart defect in the child while the child is still in the mother womb. And then if you suspect that, then you can send the child now for intrauterine echocardiogram, or you can see the defect. And in normal day in advanced country, some defect can be corrected while the child is still in the womb of the mother.
Wow, that is awesome. Interesting. So to follow up on that, so can this be passed on from generation to generation? I think that's what most people want to know. Can if maybe I say my aunt or mom had it, is it most likely that their child will get it as well?
Well, there is no clear-cut evidence to see
Okay.
that congenital heart defect can be passed from parent to offspring. But remember, we say there are some genetic problems linked with most of the heart defects. So if it is good for you to find out in your family, okay, if any of your relative in the past, meaning the first line relative, have similar disease, just to increase your suspicion. Okay, but evidence, research, okay, have not proven that yet. Is there a theory, okay, postulated that, okay, since it's genetic, we know that genes sometimes runs in family line. Okay, since it can be genetic related, it's good, okay, to investigate your background. But to say like if my mom have, and me, I will have it, it's not been proven yet.
Yeah, not yet found. Okay, that's good to know.
Maybe
so I noticed
that the black give out there only because he us.
That is so true. So also another question for the non-medical people, you mentioned that the two different ones are acyanotic and cyanotic ones. Could you maybe tell the public what the cyanosis means?
Okay.
So they have an idea.
Yeah, sorry, I jumped over that point. When we say cyanose, it means the child is getting blue. Okay. I don't want to dare into which one. I'm not sure the problem will benefit which one will make you blue. But we say the child has cyanotic heart disease. It means that oxygen delivery to the body tissue is very low. So the child begins to appear blue. So the child lip, okay, start getting blue. The fingers, okay, start getting blue. Okay, the skin start getting blue. Those are the cyanotic heart disease. The acyanotic ones are the ones that the child has the heart defect, but there is no compensation. Okay, that oxygen blood, okay, is still be delivered to the tissue. So in those children, you do not see them getting blue. So once the child has a heart defect and he's not getting blue, we say it's acyanotic. If the child has a heart defect and we see that the child having blue discoloration of the lips, the skin, the fingers, and we say that is cyanotic heart disease.
Okay, awesome. This is also a boost for my own reminder. So the last question that I have is, you mentioned the two types of treatments, the medical and surgery. Can you tell us any kind of particular medical treatments that are usually used?
Medical treatment depends on the complications or the child's symptoms. Most often, as I said, we try to stabilize the children. Some kids outgrow the defect. There are some conditions you do not need to intervene immediately. Wait for 1-2 years and see, okay, if the child will outgrow it. So these kids, we follow them. Okay, if that increased pressure, we give medicine that will reduce the pressure. Okay, if fluid is accumulated, the child getting swollen, we give medicine to reduce the fluid. So we give the medical treatment to see, okay, for the stable patient. Okay, you see
Hello, I hope it's not on my end. Okay, so we kind of lost Dr. Hart for a minute. Okay, so while he's joining, if anybody does have any questions, you can type them in the chat, or as we are waiting for Dr. Hart to join, you can feel free to unmute and ask. I did want to point out something when he mentioned about isoretinol, or we call them retinoids, and him saying that it could be a risk factor for congenital heart disease. Actually, before someone takes retinols, maybe for acne or it's vitamin A, usually the OB will ask you if you're on OCPs, are you trying to get pregnant, or are you in the process of getting married or pregnant or something. So they would ask you in case so that they will tell you about the side effects just beforehand. So just to add that on for anyone who's interested in the OB/GYN side effects. Okay, Dr. Hart, do we have you back?
I'm sorry, I had interruption.
It's okay. It's okay. No problem.
Yeah. Okay. What I was saying is that the medical decide which way you go. One, the child's condition or presentation. It's something that needs emergency intervention, or is it something that you can watch to see? Two, the type of disease the child has. It is a one that the child can outgrow, or it's something that the child will not outgrow. If you not intervene, the child will get seriously sick in the next term. The next one is the symptoms. Okay. If the child presents with hypertension, you have to give antihypertensive medication. If the child presents with fluid overload, you get diuretics. If the child presents with respiratory tract infection, you have to treat the infection. So those are the situations in which we give them. As I said, some kids will outgrow some of these defects as they grow up. So we wait to see those ones that can be outgrown.
Okay. Thank you so much, Dr. Hart. So on my side, I've run out of my questions. So if anyone does have any questions, feel free to type, or you can unmute yourself. This is the time for Q&A before we end our lovely show for today. Are there any questions from the crowd? I'm giving you the opportunity to either ask or you can type them in the chat box.
I have a question.
Okay, go ahead.
All right, so my question, good evening, everybody. So my question is to Dr. Hart. I want to know if it is it a must for a woman in childbearing age to use folic acid? Because you have said that in your presentation. So it means that for every woman who is in the childbearing age and sexually active or married of a sort, they have to take folic acid to avoid a neurotype defect?
No, we know you don't want to the vitamins, the supplements should not be taken continuously in life. We see that a lady of childbearing age that is planning for pregnancy. Okay, as I said earlier, if you and your partner planning to have a child, okay, and you are in the process, some family discuss, okay, we will try to get a child next month. Okay, we see in that case it's advisable, it's not mandatory, so you must. But some studies have proven that early folic acid use before pregnancy help many defects, not only congenital heart defect, even spinal cord defect. Okay, it also helps to reduce the risk or the chance of you having one. However, if you have a family line of history of first line family history of birth defects in your family, then it's highly recommended that you use such. Otherwise, it's not mandatory. Did I address you somehow? Okay.
Yes, thank you.
Okay, thank you, Dr. Hart. Does anyone else have a question they'd like to unmute and ask, or they can type it in?
So in the same idea about having supplements before a woman gets pregnant, and there are those women who ingest alcohol, ethanol and all. So what if they find out that they're pregnant, and later on, it's like, let's say, because some people, they actually do find out when they're pregnant, maybe 5 weeks later or 6 weeks later. Is it a problem? Because I had a patient who once came to me and was asking to me, like, is my kid going to have a congenital heart disease just because I was taking alcohol the past couple of weeks, So why would you have?
Okay, These issues are things that you have to approach them with high level of sensitivity. In real life, it's not like if you take a bottle of alcohol this week, it means that you're going to have a child with congenital heart disease. It depends most of on the duration and the quantity of the substance you take that will increase your risk. So that will just advise, if you tell them so you can take a little bit of alcohol, no problem, everyone will begin to take alcohol. And then you're not going to measure the quantity, and the degree of exposure they will be, exposing themselves to. But if the mother consumed, one bottle or one cup in the past week, okay, advise her not to do it again. Make her understand, okay, that increased consumption, will increase your risk. So if you don't want to have a child, with heart disease, okay, don't take another one again. Okay, but the duration or the frequency and the quantity increases your risk of heart disease, especially, okay, in the first trimester where the organs are being formed. Okay, at that time, we don't want to go around it. But if the mother have taken it, then so she take a huge quantity before she get to know, and she have established it that I've been taking it for a long time now, it's 5-6 weeks. You just have to monitor her. Okay, then she's a high risk patient, okay, of having a child with congenital heart disease. Then you make sure you increase your surveillance. Okay, when she come, you want to, by the age of 18 weeks, 16 weeks, you want to start, checking the child for any difference. So far, so good. Maybe the OBGYN will say more about that.
Interesting. I like the connection with the OB/GYN. Thank you so much, Dr. Hart. Are there any other questions from the crowd? Does anyone else have a question? If you're shy to talk, you can type it in. I'll give you guys a few seconds. Okay. Oh, I have one question here. Someone asked, can somebody who has a congenital heart disease outgrow it as they become an adult?
Yes, okay. I think Polly is on now. She says she was finding problem to log in from the other phone. So after this question, we can have a chance to say something. Yes, as I said earlier, okay, there are few conditions that the kids can outgrow. That is why sometimes we say we introduce medical therapies. Okay, yeah. For example, people with small PDA, okay, small hole between, okay, the pulmonary artery and the ductus. If it's small millimeter, you don't have to rush take that child for surgery. Sometimes they close by, but we have the age limit. Okay, at this stage, we say at this age for this condition, if this lesion is not resolved, it means that the child will not outgrow it. There's some defect, VSD, ESD, depending on the size of it. Okay, we'll wait to see the defect may just close. Okay, by natural in the process, but there is a limit. Okay, that we say, I mean, it's spelled out, it's been proven by evidence that at this age, if this child has not outgrown this defect, he or she will definitely not outgrow it. However, while you are waiting for the child to outgrow that defect, if the child develops complications that you think, okay, it risks the child in life, you have to intervene now. Now you can't wait again. You have to take the child in for surgery. But yes, to your question directly, there are some defects, okay, that the child or the children can outgrow.
Okay, that's good to hear. I hope this answered your question. Are there any other questions from the crowd? Feel free to unmute yourselves and ask before we close. Any questions from the crowd?
If Polly is running, you can ask if Polly is on our other host, our guest.
Oh, okay, no problem. Any last questions from the crowd before? While we still have Dr. Hart here in his busy schedule, if anyone has any last questions.
And Polly, if you are there, Polly, if yes, you are on, you can come in, Polly.
I don't see Dr. Pauline here. I'm not sure if she's here. Okay, there's one question. Is there a strong association between Down syndrome and congenital heart disease, as you mentioned in the presentation, in the discussion today? Is there evidence or, yeah?
Yes, many researchers have proven that there is a strong association between Down syndrome and congenital heart disease. As we said earlier, Down syndrome happens to be the commonest genetic syndrome associated with heart disease. But the actual pattern, that predisposes the child to that have not been very clearly defined yet. But yes, there is association, with Down syndrome and congenital heart disease.
Okay, thank you. I hope that answers someone's questions. So I'm going to give one last minute for any questions before we thank Dr. Hart for his time today. Are there any last questions or comments from the crowd? I'm going to give you guys a little bit, few seconds before we, before I close out this section. Okay. Going once. Going twice. Okay, I hope everyone that means that everybody was satisfied. So Dr. Hart, on behalf of the ICMFEL, I'd like to say thank you for coming today.
There is a question. There is a question from Facebook. Yeah, there's a question from Facebook. Let me just get it here. It says,
okay, because I can't.
Yeah, as I can see the Facebook and YouTube questions. Is there any treatment that a child can be placed on before surgery? Like specific treatment, is there any specific treatment a child can be placed on before surgery? That's from Facebook.
Okay. To address that question, I would say it depends on the condition of the child at the time of preparation for surgery. If, for example, let's take one, if the child have a huge PDA, that the child had this overload on the lung, sometimes we have to put the child on diuretics to reduce the volume before we go for surgery. So it's not like every patient will have to go on medication. Sometimes if the pressure is high, we have to moderate the pressure before we take the child for surgery. If we observe during the time of preparation for surgery, the child have other medical conditions, like maybe the child have lung infection, pneumonia, we'll have to treat the pneumonia. If the child have other infection, we'll have to treat the infection. So those are pre-op preparations. Our patients must be free of all diseases. The patient's symptoms must be, cardiac symptoms must be minimum before we take them in for surgery. For example, let's assume the child came to me with VSD or PDA, but the child have swollen face, swollen limbs. It tells me that the child have fluid overload in the tissue. We don't want to take that child in because for the child to recover the surgery, the procedure after surgery will be difficult because the heart is already congested. So for those children, we'll have to place them on diuretics to make sure that they are lighter before we can take them in for surgery. So in short, it depends on the status of the patient, the symptoms the patient presenting. And then if we find out that the patient has some problem, then we can give treatment.
Okay, thank you so much. There's another question from Facebook. It says, so from the discussion, you said that in the US, it's about a 1 to 100 chance, and in Liberia is 8 to 1,000. That's correct, right? Is it correct? The chances for congenital heart disease.
Yes, that is the funny. Let's get it clear. In America, we have almost an adequate health system. Where patients are screened, so they are catching almost every single patient. I just told you that in Liberia, there have been no activity of congenital cardiac disease in Liberia before. Unfortunately for Liberia, I am going to be the first one coming out. We did a single center research. Sorry to make that clarity. The findings we're reporting is from a single center. That number could even increase. It could be passed by the American one. It could go to 2. If we should go in all the counties, and catch all the patients. But in Africa, most of our patients do not come to the hospital. They classify these people at wish. So our reporting, is underreported. So yes, I agree with you. There is some issue with the reporting, but we can only give the evidence we have. We did the research in a center that what we have. That's what we can give. But in real life, okay, there are biases, okay, that will make this figure not as accurate as it is. And some of the biases would be one, it was a single center research, that is a commercial center, it's not free, so most patients will not be coming there. Two, most of our patients with these diseases do not come to the hospital. Okay, most of them deliver by traditional midwife at home. Okay, so we are not catching all the patients. So I agree with you. Our figure could be higher than what it is, but as per evidence base, that's what we have.
Wow, that's a very good question. And this is why spreading awareness is important and why we hold such talk shows and why we invite amazing doctors so we can help spread awareness and get more people to come to the hospital, because that is a very big issue that we are facing in most of our home countries. So are there any more questions from Facebook before I cut someone off again? Dr. Bala, just to check in. Are there any more questions from the other platforms? Okay, I'm hoping that's a no. Okay, so okay, Dr. Bala, are there any more questions from Facebook?
No.
Do we have
Okay.
Victoria? Can you
Yeah?
search if Polly is still on?
No, I don't have her on Zoom. No.
We don't see any polling here. So.
She was using one PK. She wrote in my box directly with one.
Okay,
PK.
maybe not on Zoom. I have been checking and I
Yeah,
haven't
she's
seen her.
not on Zoom. We don't see her here. We don't see the PK either.
Okay, Dr. Hart, so that we don't take much more of your time, thank you so much for coming today, for attending, for hearing our questions, for your amazing discussion. Everyone, this is the ICMFEL, International Christian Medical Fellowship. Thank you for tuning in and hope to see you all in the next show. May God bless you and have a great day. Thank you so much, Dr. Hart, and everybody else for joining. Yes, God bless you.